I thank Dr. GVK and his team for giving me this opportunity to talk on dementia. So, dementia is the general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with the daily life. So, Alzheimer's is the most common cause of dementia. So, dementia is typically diagnosed when cognitive impairment has become severe enough to social and occupational functioning. And mild cognitive impairment is a state intermediate between normal cognition and dementia, while essentially preserved function abilities. So, a person with dementia has two or more of these specific difficulties, including a decline in memory, reasoning, language, coordination, mood, and behavior. So, dementia is mainly due to degeneration of the brain, that is cerebral neural degeneration this is a cerebral neural degeneration in dementia. So, the hallmark of dementia is beta amyloid plaque, which are the dense deposits of protein and cellular material that accumulates outside and around the nerve cells, whereas neurofibrillatory tangles, which are twisted fibers that built up inside the nerve cells. So, in the left side of the picture, you can see a normal brain, and the right side, you can see this Alzheimer's brain. So, Alzheimer's brain tends to shrink due to loss of neurons. Let us see the prevalence. Global prevalence of dementia, which was published in 2023 by WHO. So, more than 55 million people have dementia worldwide, over 60% of whom live in low and middle income countries. So, every year there is nearly 10 million new cases of dementia globally. So, prevalence of dementia in India, the estimated dementia prevalence for adults age 60 plus in India is around 7.4%. About 8.8 million Indians older than 60 years live with dementia. So, dementia is more prevalent among females than males in rural than urban areas. There is also a significant cross-state variation exists in the prevalence of dementia in India. So, dementia can be divided into three groups, that is primary, secondary, and reversible dementia-like symptoms. The primary is due to main pathology and destruction happens in the brain itself, like Alzheimer's, and the secondary is due to some other pathology causing damage to the brain, like vascular dementia, then repeated stroke, and there is reversible dementia, that is symptoms like other causes due to vascular dementia. Less than 5% is due to dementia with Lewy bodies, and 2% is frontotemporal dementia. More than 10% is mixed dementia. So, secondary dementia due to other disease and conditions. We have Huntington's disease, Parkinson's disease, Creutzfeldt-Jakob disease, Wernicke-Korsakoff syndrome. It is due to deficiency of B1 vitamin, and again traumatic brain injury, that is repeated blows to the head can cause this injury, particularly in boxers, football players, or soldiers. Let us see the dementia due to reversible causes. So, that is normal. See, some condition can cause dementia-like symptom that can be reversed with treatment, which includes normal pressure hydrocephalus, then vitamin deficiency like B1, B6, B12, and E, infections like HIV, syphilis, Lyme disease, urosepsis, and pneumonia. In COVID also, a lot of patients had a dementia-like picture, that is due to brain fog and acute delirium. So, metabolic and endocrine conditions like Addison's, Cushing's, then hypoglycemia, exposure to heavy metals like arsenic and mercury, hypercalcemia, liver cirrhosis, and thyroid disorders, and also medication side effects like hypnotics, then anxiolytics, antidepressants, anticonvulsants, then non-benzodiazepine sedatives, and narcotic pain relievers. So, diagnosis, we have two things. One is laboratory and imaging studies. So, laboratory tests are mainly to identify inflammation, hypothyroidism, vitamin deficiency, and also cerebral final fluid test to evaluate autoimmune conditions and neurodegenerative diseases. So emerging studies, we have computer tomography, magnetic resonance imaging, and FDG PET scan. So you can see the two images, one is with the red and other one is blue. Red is normal brain functioning because the glucose uptake is good. So where you can see the red color, FDG is good. Whereas in the left side, due to loss of neurons, FDG is not taken, and you can see absence of metabolic activity in dementia. Cognitive assessment test for dementia, mini mental state examination. It is the most common screening test used for assessing cognitive impairment. You have mini cog, that is a brief 3 minutes questionnaire, then general practitioner assessment of cognition, and Montreal Cognate assessment. Let us see the complications of dementia. So poor nutrition, many people with dementia are reduced eating, and they reduce drinking fluid also, which leads to poor nutrient intake and malnutrition. So dehydration in particular is very important, which can precipitate renal failure, stroke, and MI. Then inability to perform self-care, that is dementia progress. People find difficulty in bathing, dressing, brushing their hair and teeth. They constantly need a caregiver's assistance for toileting and taking their regular medications. Due to disability, they are prone for injuries and traumatic fractures from falls. The other thing is personal care and safety challenges. Even day-to-day situation can present safety issues with driving, cooking, and walking and living alone. Bed sores is a very, very common problem. Many patients develop bed sores, and special beds like alpha bed and water bed can prevent this issue. Pneumonia is very, very common in people with dementia because of inability to swallow, and lying down position can lead to aspiration and aspiration pneumonia. The reason for death in people with dementia is coma and sepsis due to pneumonia. So let us see the different stages of Alzheimer's disease. People in mild stage of Alzheimer's disease are still able to function on their own. It is very, very important. They can be able to function on their own. They may still drive, go to work, and socialize. Some challenges are happening that may or may not be noticed by the person, but the people around them, like family members and friends, notice some changes. These include trouble remembering a person's name after being introduced, losing or misplacing multiple objects, having hard time coping up with the right word consistently, trouble planning, organizing, managing, and completing tasks, constantly forgetting what they have just done. This is very, very important. Because each stage is important, because we are going to choose how we are going to manage the patients with that particular stage. So middle stage, here people in the middle stage they can take part in everyday activities with the help of others, whereas in the first stage they can function on their own. Symptoms are more obvious. They have confusion about year and season, where they are forgetting events like phone number, address, then changes in personality, mood, behavior, then changes in day-night sleeping patterns, and also difficulty in controlling bladder and bowel movements, and also wearing inappropriate cloth for the season or occasion. Many times they tend to wander and they get lost because they don't know where. We have come across many such patients. They will go for shopping or somewhere and they get lost. So late stage of dementia, so they completely depend upon other people, and they have loss of awareness what is going around them. So difficulties may include trouble communicating, which may include only being able to say few words, trouble walking, trouble swallowing, being more prone for infections like pneumonia, and requiring 24 hours assistance for their care. So let us see the health and well-being of elderly people with diabetes and dementia and family carers. So management of diabetes and prevention of hypo and hyperglycemia is very important. So management of cardiovascular risk factors such as hypertension and hyperlipidemia, which Dr. Mahadevan has very clearly told how to manage these patients. So again, identification, management, and prevention of long-term complications such as depression, visual problems, and neuropathic complications. And also, we have to see how they are adherence to taking their medications. So knowledge and quality of life for older people with dementia and their family and caregivers. Let us see the impact of dementia on diabetes management. So we always see worsening of glycemic control, not turning for review or unexpected hypoglycemia episode should alert the clinician towards the possibility of cognitive decline of the patient. So patients may not be able to remember to take the medications appropriately at times, and also not able to recognize hypo and hyperglycemia, so which leads to higher A1C values. So it is important for healthcare profession to highlight the diagnosis of dementia and take a proactive role in seeing these patients to ensure the well-being of the patient and the family members. So impact of dementia, again, it is necessary to remind clinicians that cognitive decline in a patient with dementia is variable. So we have to see where the patient is, whether he has in mild, moderate or severe. It depends upon for the treatment. So setting glycemic targets for trending diabetes should be patient-centric and individualized, considering other comorbid condition of the patient. A patient with mild cognitive impairment may require more focus on micro and macrovascular complications and relatively tight control of diabetes. However, a patient with more advanced dementia may require laxer control of diabetes, more focus on symptomatic relief from hypo and hyperglycemia, and less worry about vascular complications. So patients with early stages cognitive decline may be manage their diabetes themselves, and as a cognition decline, the compliance with medication may also prove difficult to assess, and the responsibility of management and medication administration may fall to the family members or the caregivers. So these aspects are central to management of patients with diabetes and dementia. And while difficult to recommend to follow frequency, healthcare professions should assess the knowledge and self-management skills of the patient sensitively at each visit. That is very, very important, and also to document it very clearly. So hypoglycemia can present as an uncharacteristic behavior at times, which can easily be misinterpreted as a declining mental status. Patients with dysphagia may find it difficult to explain hypoglycemia experience. Cognition decline and dementia progression can lead to reduced appetite and nutrition, which can lead to depletion of glycogen storage in the liver and muscles, which is going to be a challenging when they have severe hypoglycemia. So CGM can give a clear picture how the trend is, blood sugar trend is. Again, uncontrolled hyperglycemia can lead to ketoacidosis. So let us see the glycemic targets for people with dementia. So ADA recommends glycemic target to be little bit lesser. Mild to moderate to cognitive impairment, they can have less than 8%. Fasting can be 90 to 150, and postprandial can be between 100 to 180. If they have a severe cognitive impairment, they recommend less than 8.5% as a A1C target, and fasting can be 100 to 180. Postprandial can be 100 to 200. So let us see various drugs. Let us see metformin is better avoided in view of risk of renal impairment, gastrointestinal side effects, and comorbidities that can limit the use. Sulfonylurea is better avoided because of risk of hypoglycemia. Glitazones, again, it poses problem of weight gain, fluid retention, and risk of fractures. So meglitines, we have very limited evidence. So DPP-4 could be ideal drug of choice if there is no contraindication. So GLP-1 agonist, again, it is going to cause decrease in appetite, and loss of appetite can lead to poor nutrition, so it's better to avoid. SGLT2, again, will lead to UTI, thrush, and confusion and comorbidities. So insulin, we have to choose the right insulin. So insulin, particularly regular insulin and NPH, which has a peak, can pose a problem because it has a variable in that is inter-individual variability. So basal and bolus regimen with a smaller dose of insulin is ideal to prevent hypoglycemia, significant hyperglycemia and ketonemia if the patient caregiver is good in that. Long-acting insulin regimens, either by themselves or in addition to oral therapy, are useful in preventing hyperglycemia and keeping sugars reasonably without aiming for tight control. So key messages: pharmacological management of diabetes in dementia is very important due to various categories of medication and potential risk associated with each agent. So individualized care plans regarding the therapeutic management should be planned and implemented by physicians, multidisciplinary team to ensure quality of life and safety of the patient. Avoid NPH and regular insulin as we discussed. Glargine, degludec and detimir are ideal basal insulin analogs if cost is not a issue. So sulfonylureas, metformins, then again SGLT2, glitazones, AGI and GLP analogs are better avoided because of their negative impact on comorbidity in patients with various stages of dementia. So CGM is ideal for monitoring the blood glucose. If cost is a constraint, so you can choose CBG. Periodical frequent monitoring of blood glucose is important as it gives estimate of glycemic trends for adjusting the insulin dose. So DPP-4 is ideal drug of choice if there is no contraindication. Short-acting and ultra-short-acting insulin analogs can be considered if appropriate support is available from the caregivers. I'll stop here. We'll take questions at the end of the session.
Thank you, Dr. Chandru, for